This first day, second show of the AIOC meeting, and welcome first of all to my esteemed faculty and all of you who are here early in the morning for this preferred practices and controversies in pediatric cataract management. I am Dr. Vaishali Vasavada from Raghudeep Eye Hospital, Ahmedabad and Jaipur. And as you can see here, we have a star-studded lineup of speakers here, and I'm sure we will make most of this opportunity, all of us, to interact with each other and ask questions and doubts and learn from each other. So I will start without much ado. We want to keep in time with my talk on IOL implantation in infants and children below the age of 2 years. What do we know by now? And I have no financial interest in this presentation. So I think we all understand that the objective of a pediatric cataract surgery is as much as a technical outcome and as equal amounts of functional outcome. And often it is this functional outcome in terms of trying to prevent amblyopia and stereopsis and binocularity. This is where we often lose the battle or we fall back in our management. So primary IOL implantation, I think we all understand that by now it is very, very much in vogue, and people implant in as young as children below the age of 2 years. But I think it is in the infants, and particularly those below the age of 12 to 18 months, that it is still, let's say it could be a controversy, not because of its scientific merit and demerit alone, but also because of many other factors, including your technical expertise, including the ability to follow up, and so on and so forth. So I think we all agree, I think experts around the world and across the globe agree that above the age of 2 years, it is safe to implant a primary IOL if you can do it in the capsular bag. And particularly in unilateral cataracts and more so below the age of 1 year, this IOL implantation still remains controversial. I think in my mind, at any age, whether it's a small baby or an older child, any child with a horizontal corneal diameter of 10 millimeter, it used to be 9.5 millimeter cutoff for me, but I have pushed it to 10 millimeter. Anybody who has microphthalmos, that means an axial length of less than 2 standard deviation for their age, and anybody who has intraoperative problems where you could not do the rexes the way you wanted, or you had a lot of iris tissue manipulation, and you feel that you are not 100% confident in putting the lens in the bag. I think this is one of the biggest contraindications that even if you had planned an IOL, even if you had counseled the patient, it makes sense to go back on your plan and leave the child aphakic. Now let's go on. Before we move on to my preferred strategy, let's see what the international literature says. So a lot of you might have heard of this infant aphakia treatment study and the American Academy report. They both have said that primary IOL implantation should not be performed when the child is under 6 months. And again, like I said, the IATS, which was a unilateral cataract study, at 10 years follow-up, they found more complications in terms of more resurgery rates in pseudophakic eyes. So the Western world seems to say that do not implant an IOL below the age of 6 months at least. But we live in a different geography, plus the fact that if you are an experienced surgeon and if you can follow up the child by rigorous examinations, performing anesthesia when needed, refractions, and take the child up for resurgery as and when needed, it may often be a better option in terms of an early visual rehabilitation. So again, another study where the toddler aphakia, pseudophakia study, the TAP study, where again they said the same thing, that once you operate bilateral cataract in infants below the age of 1 year, then IOL increases the risk of a visual axis obscuration. Until a few years back, there was no evidence in literature in bilateral cataracts below the age of 2 years whether we should implant or we should leave them aphakic. A lot of us do believe even today that giving them aphakic glasses or contact lenses is as good an option as doing a primary IOL. But we did a randomized clinical trial published in the AJO in 2018, where we found that when you performed bilateral in the bag IOL implantation in cataracts below the age of 2 years or even below the age of 6 months, If you can do an in-the-bag IOL implantation, the complications were very similar except for a little higher incidence of posterior synechiae, which obviously are more visible when there is an IOL. We cannot see the mid-peripheral synechiae which may be occurring in aphakic eyes also. And in fact, the rate at which, this is very important, I want you to note, the rate at which vision developed in the early post-operative period, that means 18 months after surgery, there was a much faster visual recovery in pseudophakic eyes as compared to the aphakic eyes. Although finally at 5 years follow-up they reached the same point, but the steep climb was much higher in pseudophakic eyes. So I think the message that I want to give is that if you feel that you can technically achieve a good anterior-posterior capsular opening, whatever method you may use, and then put an intraocular lens in the bag, then that should be performed in any eye that is anatomically suitable to take the IOL. The caveat being a rigorous follow-up and often under anesthesia. You may need frequent EUAs to examine these children. Now let's go to the methodology. If you do decide to implant an IOL, what are the options available to us? I think we all understand and we all have been doing anterior posterior capsular excis and in the bag IOL along with an anterior vitrectomy. Now here again we have two good options. I don't think it should be an ego issue that you should be able to perform a manual posterior capsular excis of a fixed size and centration. You can also do an anterior excis, put an IOL in the bag, and then go with your vitrector from the pars plana route and do a pars plana capsulectomy vitrectomy. So this still is a very good option, putting the lens in the bag. Now material, without any financial bias, even today I think hydrophobic acrylic single piece IOLs are still the best choice because of the fact that they are time tested in terms of inflammation and the occurrence of visual axis obscuration. Like I said, there is no ego. Not everybody every time can perform a manual posterior capsular excis, no problem. In that case, perform an anterior excis, remove the lens material, implant the IOL in the bag, and then as you can see here, I have pre-implanted a trocar about 1.5 to 2 millimeters behind the limbus, through which I am introducing my 23 gauge vitrector. It's a regular phaco machine. It doesn't have to be a Venturi vitrector machine. And with the highest possible cut rate on your machine, you put the irrigation through the corneal side port and the vitrector goes behind the IOL and perform a capsulectomy vitrectomy. So the comfort of having achieved an in-the-bag lens is still there and you are not worried that your PCCC was not of the right size and shape. So this is a very good option and sometimes I do resort to it, particularly in children below the age of 6 months. But the last and the most important segment of my talk is, can we avoid this whole vitrectomy, which is supposed to be an integral part of cataract surgery, whether or not you implant an IOL? And which brings me to now our preferred technique across our hospitals, all surgeons, optic capture. Dr. Howard Gimbel was the first one who deserves all the credit for describing this technique in children. Basically, you perform an anterior posterior capsular excis, put a 3-piece lens in the capsular bag and then push the optic of that IOL behind the posterior capsular excis. And here is a video to show you how it is performed. This is a standard white cataract in a pediatric eye, and you can see here that an anterior capsular excis is performed, a posterior capsular excis which is 4 to 4.5 millimeter. You don't need to measure, but it should be around that size. Now once this 3-piece lens is in the bag, I'm using my dialer or a Lester hook to just slide the optic behind the posterior capsular excis margin, and the same thing is being done here. So achieving this dumbbell-sized appearance is the end point of a good optic capture of the IOL. But mind you, no anterior vitrectomy has been performed. I perform a triamcinolone staining after this just to make sure that there are no vitreous strands. And this is again a follow-up of the child 3 months following optic capture. And this is 1 year where you do see some phimosis coming up, but the central visual axis is absolutely clear. And these are pictures from 3 years follow-up from an EUA that has been performed, and again you can see crystal clear visual axis here. So what the optic capture does is basically the anterior and posterior capsule leaflets fuse and they block the proliferation of lens epithelial cells towards the center. But what it does as a by effect, which we realized later, is that a captured lens will be so stable in the capsular bag, as you can see through this animation, it will not move at all, versus an in the bag IOL is liable to move anterior posteriorly or laterally. So it locks the epithelial cells and it gives us extreme stability. We published a few years back 1 year outcomes of in the bag IOL and anterior vitrectomy versus optic capture and no anterior vitrectomy in pediatric eyes. And what we found was that the incidence of visual axis obscuration was nil in optic capture eyes, and they were both comparable in terms of their vision and complications. So I think optic capture, it's difficult to perform, it has a little steep learning curve, but if you can, please start doing it in older children. You can do away with one whole procedure of vitrectomy, which who knows what side effects it has in the long run in these children. So I think I would like to end my talk here by saying that start with older children, whatever the technique you use. And it is very, very important that we take in mind the complications, the ability to follow up the refractionist. We should have all the backup before we think of implanting in children below the age of 6 months. Thank you. Any quick questions or comments? Please. You can take the mic up there.
Of where you didn't do a vitrectomy, what was the IOL cover you chose? The same as that of the bag, or was it any?
So that's a very valid point, that when the effective lens position shifts a little posteriorly, you should ideally undercorrect your IOL a little bit. But in this case, because really pediatric eyes, particularly those below the age of 2 years, everything is such an enigma. We usually undercorrect by the standard age appropriate nomogram that we use. We don't make any alterations for the optic capture. But yeah, you could use about anyway you don't get steps less than half a diopter. So half a diopter you can adjust for that. Absolutely. So I think we move on now to the talk that I'm really, really looking forward to in this course. It's my honor and pleasure to invite on stage Professor Dr. Jagatram sir, whom I've been learning from since many, many years, and today I hope to do the same. And he will be talking to us about the surgical paradigms of a pediatric cataract surgery.
First of all, I am thankful to Dr. Vaishali Vasavada and Dr. Vasavada for giving me this opportunity to participate in this instruction course. I will be speaking on the surgical tips for cataract surgery in pediatric eye. I always remember my teacher, because as the person grows senior, we remember that, because younger people, they forget their teacher. Because I am realizing I have experience of 44 years in the ophthalmology. So I owe my gratitude to my mentor and teacher. They were my teacher at PGI MER Chandigarh. I also owe my gratitude to mentor in pediatric cataract surgery. While I was working with Dr. David Apple, I got opportunity to work with Dr. M.E. Wilson, and I consider Dr. Vasavada, whatever I learned for the last, I think, several years, more than 30 years, 35 years, is particularly pediatric cataract surgery from Dr. Vasavada. While you see these children, while they come to your clinic, they come with visually significant cataract occupying even larger area than the visual axis, or it is quite significant cataract. Surgical tips for pediatric cataract surgery, I will take some of the points. Already Dr. Vaishali Vasavada has highlighted. There may be some overlap, but these are the normal cases what we do in such patients. We dilate each of the eye of pediatric of the children to see the morphology of the cataract. Whether it is a zonular type of cataract, or it is a lamellar, or whether it is because you will detect so many issues such as PHPV, or there may be other some posterior lenticonus or even complicated cases. So I think I consider it essential to dilate each of the eye. Then we have to select the IOL power. IOL power calculation is quite important because in these growing eyes, there is likely to be surely I think a myopic shift. We have to consider whether to implant IOL or not. As Dr. Vaishali Vasavada said that initially I used to think that okay, it is safe to implant IOL in 9.5 millimeter corneal diameter or more. But now as we grow senior, we feel that what to do, what is the safer limit. So 10 millimeter at present, or if there is any complication during surgery and you cannot implant IOL into capsular bag, I think it is better to defer implantation of IOL in these cases. And there are other issues of marked inflammation, its management, and as well as management of amblyopia. Our goal is to provide a clear visual axis and ultimate visual rehabilitation. These are some, I think, more than 30-year-old photographs. That time you see on the extreme left there is this PMM IOL, Pharmacia IOL we used to implant that time. Even now we see these after doing primary posterior capsulotomy and implanting IOL in the bag, they have clear visual axis. I will be showing some of the basic steps. What we do, we make first side port incision and then stain the anterior capsule. Whatever you may be expert in doing the axis, but this is just to demonstrate as well as I think what we follow. It gives a very excellent precision of the form to continuous curvilinear capsular axis, and slowly, steadily you continue and complete the axis. And this is completion of the axis followed by hydro dissection. And then all of the cortex from the capsular bag. Take time to remove all the cortical material from the capsular bag. And then starting with the posterior continuous curvilinear capsular axis, initial week by middle cystitome and then completion by utrata portion. And we expect not much of the disturbance which occur here, almost minimal or no disturbance, but still there may be some vitreous traction a bit. Then our aim is to implant IOL in the capsular bag, and IOL of choice is hydrophobic acrylic IOL. At no point of time I have implanted silicone IOL. Of course, PMM IOL several times I have implanted in the beginning. And you find perfect axis. While you do perform posterior continuous curvilinear capsular, you may find traction like this. This need that if you put triamcinolone dye, and that will stain that traction, and you end up in round. This is the same child where you find a round posterior axis. And then I will show posterior optic capture. These whatever cases I am going to show is absolutely, these are the normal, not abnormal such as lenticonus or any of the PHPV or like that. So this is how we do. So here it is staining of the anterior capsule. Main incision and small nick in the continuing with the continuous curvilinear capsular axis, and then ideally you have to keep posterior axis also make it little bigger. So while you capture the IOL optic into the bag, it will give excellent result. And then we have carried out study also in children, although it will not add much because we can do good continuous curvilinear capsular axis and implantation of the IOL, but we have done pediatric cataract surgery in children, and here even location of the side port incision and main incision, where to make, we can choose that. And otherwise finally confirming the length and position of the main corneal incision and side port incision. And I think this help only in performing mainly the continuous curvilinear capsular axis, because cortex is very soft, it will not add much. So they are staining the incision and here injecting viscoelastic and opening up the main incision. And then of course I think it is not difficult to remove the cortex from the capsular bag. Here we have not done the posterior capsulotomy with the hematosecond, but manually. But because we can make almost close to perfect, or most of the time we can make excellent posterior continuous curvilinear capsular axis, then implanting IOL into the bag. And then removing any of the vitreous tag or viscoelastic from the capsular bag. So this is but we always put in smaller children, the younger children, we put suture at the main incision, sometimes even on the side port incision. This is the last video clip. Here, if in a normal child, 5-year-old child should be cooperative. If there is a astigmatism, older children, 5 year or older, because even up to 6 year it is considered, and studies have shown that there may be decrease in the astigmatism. So at least 5 to 6 years of age group, marking was possible in this child. Staining of the anterior capsule with the trypan blue dye. And performing, I think, repeatedly these continuous curvilinear capsular axis and other steps. If we perfect them, it is perfected for life. And this is continuous curvilinear capsular axis, and then removal of the cortex after hydrodissection from the capsular bag. And here we see the removal of the cortex from the bag. Here we have also done primary posterior capsular axis, size about 3.5 and IOL is rotated to the desired position. This is at the end of surgery. This is the opposite eye which was done about documented 3 weeks back. This surgery was done. So this is also a viable option in selective cases. But I think what I feel that long-term follow-up is important in these pediatric cataract surgery children. This is one child which I operated in 1997. That time only it was beginning of primary posterior capsulotomy and implantation of capsular implantation of IOL. Now 25 years later, this child is now doctor. He has completed his MBBS only 2 years back. So I feel that these are the word of the illness which are very important, that young children with IOL in place are a unique clinical responsibility of an ophthalmologist. So long term follow up is essentially important. I think these are, so once again I am thankful to Dr. Vaishali Vasavada and Dr. Abhay Vasavada. I feel that family is most important, and because that is our strength. Thank you so much.
Thank you, sir, for those really multitude of tips that you gave us. And does anybody in the audience have a question or a comment? Please, could you come up to the mic, please?
Okay. Do you hear me? Yes. In case you're implanting the toric IOL, do you need to remove the viscoelastic behind the IOL to prevent rotation, or do you optic capture it to prevent any rotation post-operatively?
Yeah, definitely. I think question is viscoelastic. Viscoelastic, whatever we put into capsular bag, implant the IOL in the bag. So from behind also, behind the IOL optic, we have to remove the viscoelastic. Of course, front we remove whole, but it is quite important to remove that viscoelastic, because IOP goes high with that viscoelastic in children.
But in the presence of the posterior CCC, how do you do it? I mean, safely.
No, I can.
If there's a PCCC, how do you remove from behind the IOL?
Yeah, even then what we do, that because IOL is in the bag, we lift one part of the optic, say superiorly or close to the side port. We lift that up and go behind the optic. That is what I do. And manipulation should be very, very limited.
Any chance of breaking the hyalur membrane? That's
Yeah.
what I would like to know.
Yeah, I think it's a very important question, and Professor Jagatram is very dexterous and he's very confident. He has done thousands and he can do that. And what I do, I'm a coward. So I do PCCC in children under 6 or 7 years. In other words, I judge, is he a laserable child? Will he cooperate later on for YAG capsulotomy, sitting there and keeping quiet? With most of the children, I don't take a risk. So I perform a small 2 millimeter or so posterior capsulorhexis on a toric IOL, single piece hydrophobic, and I don't remove. I don't go behind the IOL with open capsule. I don't care about the IOP. I treat it with mannitol. I always give injection mannitol post, just at the end of the surgery in children where I not removed it. Thing. And rotation is not an issue actually with this single frog. But you can do as he suggested, but you need to be very careful and decide how. If you rupture once or twice, forget about it. And do so. You decide your own strategy, but your question is very important. Very nice. Thank you.
Yeah, I think I agree that it's better to err on the side of leaving behind some viscoelastic. You can always do a little bit of rock and roll or tap on the IOL and give I also like to give topical IOP lowering agents in these eyes. But with all good hydrophobic single piece, the Acrisoft toric that we use, we don't see rotation so much.
And as you say, the vitreous with the small rexes will not come forward.
Yeah,
Even
yeah.
if you go behind, it doesn't come forward. But you be careful. It depends on your experience, skill, and everything.
I think that is a very right word. One has to be very careful. If you don't remove or if you remove. But I go toward the side of removal of the viscoelastic. But one has to be very careful, as sir also said. Thank you so
very
much.
Thank you. So now we move on to yet another masterclass of how do you handle pediatric cataracts with special situations. And I invite Dr. Vasavada to talk Sir, please join us on the dais. Come over.
This is my financial disclosure, but I have no relevance. And recognize the contribution of entire team in Jaipur and Ahmedabad, but Dr. Deepa Agrawal, who has assisted me in this. These questions we have discussed, but counseling of the parent, particularly in a challenging pediatric cataract, but all pediatric cataract, when would you decide to operate, safety, implant or not, and measurement, precision, we know that. But all of these are more relevant in patients, children who have little off the road or a little challenging, and this we have seen it beautifully, but I just want to highlight the importance of the closed chamber technique and using heavy cohesive sodium hyaluronate. I use Helon GV as the routine. Sometimes I use Helon 5. So only thing I've done here is the 1.1 or 1.2 millimeter incision. I stopped using air bubble because I want an extensive staining, so I use straight away trypan blue, and then I make my second port, and then I would do the third port. But this is important. And this we do it and learn from adult cataract surgery. Many of these pearls we have actually adapted from the cataract surgery we perform in adults. So being a good cataract surgeon, in addition to pediatric ophthalmologist, will be an additional mind boosting philosophy. So I'm unbent cystotome 26, 30, whatever. Introduce, hold your hand and sit in stable, fill with 2 ml syringe fluid because it will suck better. If you have an empty syringe, it will not suck better. So fill that syringe with some fluid and then aspirate. And then you are lower intralenticular pressure. And what I do, and I must recognize, I forgot his name, Nischel. Ken Nischel, he and Dr. Wilson propagated, it didn't work out that way, and this is a modification. It is not a modification, but this is something like that I do. You make an incision and grasp the away part of that slit and push away. So you will create 2 ends both sides. So both ends will be strong. What happens in intumescent cataract with raised pressure is that when you start doing on one side, left side, the right side goes out. So if you push both against you, it will create a strong margin and there is no chance of Argentinian flex sign or whatever. So, and then take your time, grasp, regrasp, and create small rexes. And Dr. Gimbel gets the credit of 2-stage rexes. He did it in a multipuncture capsulotomy, but we then published with Dr. Jagruti Desai, and we call it I and D rexes. Initial small, definitive large, because even if it's all this viscoelastic closed chamber, still the capsule being elastic can run to the periphery. So smallish rexes, sufficient so that you can have your port, and then this is the irrigation aspiration, and then now I'm going to do a definitive rexis. I can do it after putting implant, but it's difficult to put implant through this one. So I do it before implant. Sometimes I do it afterwards, but this is a more than not often, So I'm making a large sufficient so that capsular fibrosis, which is so common in these children, will be less. More the anticapsular IOL fears the capsular rexis. So that's something is important. And then you need to perform a posterior capsular rhexis later on. But take your time, grasp and re-grasp, and enlarge it to that level. I'm not able to move forward here somehow. That bar is not coming. Yeah, sorry. Can you say like this? There's no bar coming here. That thing. I want to move forward. Or we can show it in here if it comes there.
No, here you won't get a scroll.
Or forget about it then. Let it go.
So I think while this AV glitch is being fixed, one thing that okay, we are back. So let's see.
So having done the large rhexis, you need to perform a posterior capsular rhexis. And in the posterior capsular rhexis, you need to have a bent cystotome and put it horizontal and swipe from right to left if you're right-hander, and try to catch the posterior capsule and lift it up towards the endothelium, so that chance of rupturing the posterior antivitreous face will be reduced. And then control the size depending upon what the purpose is. If it's a capture, you need a little larger. If it is just a central axis clearance, 2 ml, and that's what I do in a toric IOL. But this, depending upon the purpose of PCCC, you can do it. And with some experience, generally you won't rupture the antivitreous face. Now, I'm putting a 3-piece IOL, and you can use holding folding forceps, which is my actually choice. But here I'm manipulating through the injector, and I use B injector, and the incision size is 3.4 millimeter. And I place the 3-piece haptic into the bag, and then, as you saw earlier, I'm just pushing that optic posteriorly and creating the optic capture. You could do antivitrectomy if you wished, and in a smaller children, there is nothing wrong combining antivitrectomy along with the capture. There is no harm doing both, or any of these. But certainly in children under over 6 months, you can get away without antivitrectomy for sure. So then you use the triamcinolone. These are the other cases. So this is one, and Dr. Jagatram had shown this beautiful over the years how he manages, and this is only a small part of it. We published in 2012 JCRS of the anterior persistent fetal vascular, not the one which comes from the optic disc, which is more lethal. This is okay. And this is one example to touch the subject here. And this is what you will find. You will find a fibrovascular plaque or just simple fibrous plaque, and you may find remnant or so. So here you find that thing going on, and most of this time they are ghost vessels. They don't bleed. And even if they ooze some of it, you don't need to treat it with cautery. But if you have it, it's nice. And I had to do only once or twice in my memory. Generally speaking, such antivitreous anterior hyaloid don't do any much. Now, the point is, if you aspirate, if you aspirate with vitrectomy, it will drag on the vitreous base. And so try to use non-aspirating techniques. And these Greichaber scissors from different ergonomically suited incision direction, you cut it with minimal traction and aspiration, and then you excise that plaque, and you will have to cut that stalk blood vessels. Sometimes it oozes, but it is hardly. So I'm just severing that element, and that thing which floats in the vitreous, God knows what happens to that, but it's not a clinical situation. So having attached that, I'm able to remove that. I'm careful that if I don't want to leave it out until I'm sure that there is no vitreous coming. Otherwise, the vitreous will come into the incision. So take your time and do that. And now you can consider putting the lens, and I'm putting the lens. You can put it in the bag or in the ciliary sulcus, wherever you want to put it. You have a central axis clear, and as long as it is symmetrical, that's fine. So I'm putting it under the iris as ciliary sulcus fixation, and you can capture this through your anterior capsular axis, and that's what I would recommend to do that. So this is another 6 months old unilateral cataract, and although we didn't discuss UBM, things we find very useful in UA and many of these secondary implantation and some of these mature cataract. And this is one of the lentic globus, and surgical wise it's not a big issue. You need to produce a anterior capsular axis like you would do, and then what is important then, why is happening, this is terrible. All right, so we will have to watch this, it seems. I removed the cortex now, and you can see that this whole posterior capsule is so fragile. It is sort of bowed, concave facing us with this material on it. So I'm putting the 3-piece IOL in the back, securing the IOL, and that leading haptic going underneath the anterior capsule. I'm not touching the posterior capsule, which is intact but very frail and thin, and it actually fluctuates. So now I'm removing that viscoelastic OVD, but posterior capsule is intact, as Jagatram suggested, to lift it up and do that. And now I'm going to pars plana and removing that central thin posterior capsule with some proliferated cells on antivitreous phase in that area, and also posterior capsule. So because it's a pre-existing defect, pre-existing lenticonus, there is a strong margin of that, and that will act as a posterior capsular axis and always secure the incision, as you heard Professor Ram. And this is one more case. Tell me when the time is up. When you see this granular, and I must recognize Professor Dr. Daljit Singh, who first actually described this granular signs or dots on the posterior capsule, and he related this to the posterior polar cataract and described the onion thing. But the dots are very important, and this is what we described with Raminder Singh and some other team members. What we describe and Lajja, fishtail sign like a tadpole, that whole thing moves because there is a pre-existing defect, and the whole thing moves there. So this is actually the case that because we saw the granules, we didn't have the UBM and things like that at that time. So we anticipated that defect there, and we removed that, and now you can see that the whole thing is fluttering. So we need to do vitrectomy. You can do limbal vitrectomy or pars plana vitrectomy. I prefer pars plana, but there is nothing wrong with bilimbal. Continue doing bilimbal vitrectomy if you're doing it. And quite often I do that, even now. So that's not an issue. And then you can put the lens in the bag and whatever. All right, so I think that's it. No, these are the same eyes over the period of time. I think that's fine. Yeah. All right, thank you. Right, thank you. Thank you.
Any questions, comments from the audience? I think I would like to make one comment, so that especially when you suspect a pre-existing defect, it's very important to talk to the patients and the parents that you may not be able to put an IOL the way you had planned, and that if you feel that the capsule is not strong enough to take up the IOL, you may do a secondary IOL at whatever time point you feel safe. So I think telling them of a plan A and a plan B to fall back and is very important before you actually go in the OR, because with time to come, just like adult cataract surgery, the expectations with pediatric cataract surgery have also upgraded so much.
I think definitely we always keep plan B. Although we succeed almost 90-95% in the plan A, but that margin of 5%,
absolutely,
some we have to keep.
Absolutely.
In for some special situations.
Right. Yes, please go ahead.
In Sir's hands, everything seems so simple. Regarding those posterior capsule defect where we see all those dots. What is that endpoint of vitrectomy, or should we aim to remove all those dots?
Yeah, it will come off. You don't need to catch and chase each dot because these dots are actually in the anterior vitreous phase. So lens material is getting absorbed, and these are all in the process. So when you do vitrectomy, and if you have a triamcinolone, and we should use it. The video didn't show that because it's an old video, but always use triamcinolone at the end and also before you start. Have I done adequate vitrectomy? So that's the end point. Once there is no vitreous there, you don't need to overdo it. It's not a big deal.
Sometimes those dots will be in little periphery.
That will be peripheral, but with the vitrectomy it will come. But particularly if you're doing pars plana, it's not a big deal. It will come. But even with limbal, you go and chain this thing, and it will.
Okay. So there will be a risk factor for that further opacity.
No. These are all that will get absorbed. Actually, if you really wait for 2-3 years, the whole lens will get absorbed. And this is what used to happen. The whole lens will become membranous. Only the capsules will be left with some epithelial mesenchymal transformation tissue, So this is all we have intercepted that in the process of self-resorption. So don't worry about that.
Thank you. And now we move on. We change gears from surgically managing to how do you give good functional outcomes. And I'm very happy to invite Dr. Aditya Sethi, who will be talking about paradigms of strabismus management in patients with pediatric cataract.
Thank you so much, ma'am. I would like to thank ma'am for giving us the honor to be part of this illustrious IC with such great pediatric cataract surgeons on board. So you saw what was happening with pediatric cataract surgery was only 25% of the real war. The next 75% is actual, how Dr. Jagatram sir said, is the follow-up and how we rehabilitate them. So first and foremost, we'll talk about is strabismus. A lot of our cases which come to us either with unilateral, especially pediatric cataracts, we've seen either come with a strabismus along with the pediatric cataract, or they develop a strabismus as time comes if the rehabilitation is not done properly. And sometimes even with the best of rehabilitation, still they end up with strabismus. So we know congenital cataracts are very common. It's rare, but about 2.2 to 3 out of 10,000 newborns have it, and it's a global issue, and we need to intervene as early as possible. And there often are complications to the surgery as well, which could also mean glaucoma, strabismus, excessive inflammation thereafter. So these factors of developing a strabismus after pediatric cataract surgery include if the child already has a pre-existing nystagmus, anisometropia, poor post-op visual acuity, often unilateral cataracts, and this all impacts in the real life scenario, which is binocular vision. Because often the child prefers one over the other, and that leads to a lot of limitations in the child's life. So prevalence of strabismus is actually a post-cataract surgery is recorded from a wide range. It was actually less than 4% to about 86% in children who are post-cataract. And so far it's much more than the normal 0.4 to 1.299% of strabismus which we see in general population in non-pediatric category. It's more common after unilateral cataract surgery, and its association with IOL is also being established, but that is again controversial, with some saying that there's no preference if you leave them aphakic or not. But in a lot of studies they say when we put an IOL, it's actually better for not having strabismus later on. So a lot of literature research has revealed a lot of retrospective analysis of this. So we decided to do a little bit of our own. So we went back and checked how it was happening in our center, where we found out that it was actually quite common as time goes on, and it was actually reaching around 18%. So it was actually there, and a lot of these cases were actually undergoing a secondary strabismus correction. So that was also reported in IITS, a spin-off of IITS toddler aphakic and pseudophakic treatment studies. And we've seen that unilateral cataracts actually have the higher rate. So again, more literature review. We're talking about how pseudophakic versus aphakic. We've noticed that pseudophakics did better, especially with now the advancing lenses and the advancing techniques of preventing any visual axis opacification. And comparison with other studies, we've noticed that the horizontal muscles were often the culprits. It was more of a ESO and exotropia than a vertical or any other problem. And all of this led to figuring out that maybe we need to put more earlier cataract surgeries. We have to follow them as much as we can. We have to do a proper visual rehabilitation, think of amblyopia management. Even nowadays, dioptic therapy and other stimulus can be provided. So these are the management options we have. The correct refractive correction, we have to go ahead and do amblyopia therapy. We also have now binocular visual rehabilitation, stabilization, orthoptic corrections, and then if that all that doesn't work, then we have strabismus surgery. So still we have a lot of questions unanswered. Should we always target emetropia or near emetropia, especially in unilateral cataracts, to prevent a strabismus later on? Should we use something like an EDOF or a multifocal lens to get good binocular vision, maybe more so for near, and get the use going earlier? What all sort of amblyopia therapies are actually preferred here, and does modern day pediatric cataract surgery actually prevent visual axis opacification later on, and binocular vision therapy applications, how does it affect? So I'll take cases. First case is actually a 7-month-old child with a unilateral cataract. We did a good pediatric cataract surgery that's already been described. Follow up, we saw that there was correction with refractive glasses was given, amblyopia therapy was started. After 8 months, we started noticing there's an exotropia. So the child started having an exotropia. You can see that's quite right prevalent there. And then amblyopia therapy was increased further, and orthoptic treatment was established. After 18 months dioptic therapy, you see we've actually hit the target and went closer to the other eye refraction, so there was not much to talk about there. And in about 3+ years, the child is doing much better, well aligned, by just doing the correct visual axis opacification. So a lot of times it resolves by doing the correct thing. In the second case, there's a 2-year-old with a pediatric cataract unilateral, again went for the same lens aspiration, PBC antivitrectomy, left eye recovered well. 1 month we started seeing refractive correction with glasses was given, started appropriate patching. 2 years follow-up, you can still see it's quite established esotropia of large angle. So we did follow-up, and then as time goes, as the child grows older, we decided to intervene earlier, and we did a esotropia correction with a bimedial recession. So this is just a quick video just to show everybody how we do the phonics based, if time permits. So should I? Yeah. So it's as simple as any other recession that we generally do in pediatric cases. We prefer the phonics incision, hides the scar well. So in the 8 millimeters away from the limbus, you will make a phonacial opening, and then you go ahead and you tag the medial rectus muscle. You put your sutures, then you mark your point you want to reinsert the muscle, and then after that's done, it's a very simple, straightforward closure and leaves no scar. So this was done in both the eyes to get good cosmetic correction for the child, and the child did well. Third case, this is a case with pediatric cataract, which is unilateral. Again, it came at 6 years of age, so the parents were delaying surgery. The parents were delaying the vision in this eye, saying the child was doing well with the other eye. So already had a large angle strabismus with a V pattern already set in. So first thing we did was went ahead and did the pediatric cataract surgery. On repeated follow-ups, the child visually did well, but the strabismus was pretty much there. And sorry, I don't have exact photos of this, but I'll just show a quick video of how we tackle the inferior oblique. Again, after going ahead with a phonacial opening, we first tag the lateral rectus muscle, and once that's tagged, if you have a good assistant, you can do that, or you can put a suture there. And then you go ahead and look for the inferior oblique. Make sure you get the complete inferior oblique, and after you completely isolate the inferior oblique, then it's pretty much simple. This muscle is not going anywhere. You cut the head of near the head of the inferior oblique. You take your sutures, and then in inferior oblique recession, especially if it's only 2+, I prefer to do a insertion 2/3 laterally and inferiorly to the muscle, inferior rectus muscle. So that does a good job as well. So thank you. I hope I was able to cover most of the points, and if you have any questions, we can take some.
So So Aditya, I have a question. Let's say there is a child who presents, who has bilateral cataract surgery, but has one eye doing better than the other, and obviously now develops a squint, which was already probably there. What is the age or what time point after the cataract surgery would you start thinking of squint surgery?
So, two things. Number one, if the vision is doing well, if both the eyes are seeing well and the child is alternating well, then you treat it like a alternating convergent squint, and then you plan your intervention as early as say 6 or 7 years, or maybe before binocularity is established completely. But currently, we are seeing is even with these cases, they do resolve even non-surgically if we are patient enough. So it's just about the follow-up. A lot of us come from places where we don't have good follow-up with these patients. Then we are a little more aggressive. But if you have a good follow-up, the parents understand. I think if you follow up, they do pretty well with time.
Yeah.
I would like to say that I think stability of the angle is important. So generally, when you say follow-up, we are going to be measuring the patient on each visit. And once you feel maybe over a 6-month period of time that the angles are remaining stable, vision is stable, you would probably...
Yeah.
So I think the message that I'm getting from both of you is do aggressive amblyopia therapy, repeat your assessments frequently and document the angle. But if it's stable and if the vision is anyway not improving, then earlier surgery may not be a bad idea.
So I think vision is the first criteria,
Yes, of
because your
course.
angle would really change depending
With
on
the
the vision. So if there is potential for amblyopia therapy, you would definitely focus on that before the squint surgery, because the angle really varies based on the vision.
And these are not normal eyes generally,
Yeah,
and
absolutely.
so there can be other involvements of nystagmus or a posterior segment anomaly, and that changes the way you approach them.
And if it is a sensory squint, of course, what you said, you really do have to counsel about overcorrection, undercorrection, and repeat surgeries. Much higher incidence. Aditya, I had one question, sorry.
Yeah, ma'am.
In one of your cases, you had mentioned in the 3-year-old child, dichoptic therapy for the 3-year-old child.
Yeah.
So what dichoptic therapy?
So nowadays we have iPad-based dichoptic therapy, which is recently available. So getting to that, I've noticed children are very good with tablets. So they are more visually there. We also, before this, when this was done, actually we had that option of a polarized screen and a polarized glass.
Yes.
So that worked better in younger children. They would watch a movie or otherwise. It was like an alternative to patching, not exactly dichoptic, but there. Yeah.
No doubt, I mean the management is very appropriate, but it also depends on the amount of deprivation amblyopia the patient has had. So if you operate a infant versus a 1 year versus a 2 year, a unilateral cataract or a bilateral cataract, all these would factors which would come up when you're managing these patients.
Yeah.
The other things is there could be gross anisometropia which one has to tackle. So if you tackle that anisometropia, maybe a lens exchange or maybe some kind of other things, it could help in improving the visual acuity. The third is in young children, we often do retinoscopies and sometimes we might be missing out on subtle visual axis obscurations. So that is very important to see in these patients.
Okay.
So everything is not just, I mean, just a patient comes with the strabismus, you just evaluate for strabismus and do surgery, but the cause, the pointer why it's going has to be, basically that is the first thing we have to find out and appropriately manage, as you've rightly said.
Correct. Right, sir.
So I think the whole message is key is follow-ups technically to look for anatomical complications and complications that may be having functional effects. So repeated follow-ups, and if needed, as was mentioned, you may need to do an EUA to rule out fine visual axis obscuration. So I think
one comment. It is very significant number of these children, they have strabismus.
Yes.
We never realized initially because as Dr. Jaspreet said, he said that the more there is a amblyopia, more there is an isometropia,
Yes.
correction of that first, and then of course we do it like this, as you said, you also
Yes, sir.
said.
Correct,
So it is a
absolutely.
very, very significant problem,
Yeah.
and solution is required.
Correct.
thank you. And now we move on to the last, but I think one of the most important topics of how do you deal with amblyopia and visual rehab in these children, particularly when patching may not be working or compliance may be an issue. So I'm happy to invite my dear friend and a real expert on the subject, Dr. Vaishali Shankar from Shaw Eye Center, New Delhi, to talk about what is the new paradigm or the regime that she follows to visually rehabilitate these children.
Thank you so much, Dr. Vaishali. First of all, I'd like to thank Dr. Vaishali for inviting me to be a part of this August group. So I'll be speaking about visual rehabilitation in 2024, what we used to do and what we maybe what are the new directions we are moving towards. So as has been repeated again and again, achieving a good visual outcome requires early surgical removal of the cataract, consistent optical correction of the aphakia, which means that as the residual refractive error changes, we need to be very vigilant about correcting it appropriately, and compliance and occlusion of the other eye, which still remains the gold standard of treatment. So I think this has already been mentioned, but the infant aphakia treatment study basically compared aphakia versus IOL in 114 infants. They found that the final visual acuity which was gained was pretty much equal in both groups, but 50% of the eyes had a poor visual acuity ultimately, with the IOL group requiring a much higher rate of surgeries. So they suggested that leaving the patient aphakic may be safer. But of course, we always need to remember that this was a very controlled study with glasses, lenses, patches, and all being supplied to the patients and them being monitored very closely throughout the study period. So obviously, the compliance tends to be much higher. Dr. Vasavada also had a similar study where they had 60 children with bilateral cataract. They also found that the mean logmar visual acuity at 5 years was comparable between the aphakia and the IOL group. But in our setup, first of all, of the 25 patients whom contact lens was offered, a majority of them declined to use contact lens, and even those who accepted it, ultimately only 2 out of 25 patients ultimately through the study period continued with the contact lenses, which is a very, very important consideration for us in our setup. So refractive correction varies depending on whether we have left the child aphakic or pseudophakic, and whether the child has had unilateral or bilateral cataract surgery. Aphakia, of course, when bilateral, can be well corrected with glasses, contact lenses, and secondary IOL whenever safely and easily possible. And of course, correction of residual refractive error in pseudophakia. Spectacles provide a satisfactory correction for bilateral aphakia. In infants younger than 2 years, we tend to give near dominant glasses. We also need to consider that many of these children have other associated conditions, as can be seen in this child. So they may have hearing aids, they may have a cochlear implant, and their glasses need to be adjusted accordingly. Contact lenses are an excellent optical device, especially for unilateral aphakia. And if we can counsel the parents appropriately, and the parents have some experience with contact lens use, sometimes it is more of a mental block about putting the contact lenses. Once the child gets adjusted, it is the best option. In pseudophakia, now that we are implanting IOLs even in the youngest children with a planned undercorrection of 6 to 8 diopters, 6 to 8 diopters is a very high hyperopic refractive error, which is extremely amblyogenic in itself, and essential that should be corrected. So, as has been mentioned, a dilated refraction or an EUA as required. Near dominant glasses in children younger than 2.5 years, shifting to bifocals or progressives once they are of school age, and contact lenses also need to be considered in case of significant anisometropia or IOL surprises. Coming to the amblyopia therapy part of it, what we still follow or patching is still the gold standard of therapy. Stimulus deprivation amblyopia develops due to an obstruction preventing clear formation of an image on the retina. This is less than 3% of all amblyopia, and universally it is acknowledged that this is much more severe and resistant to treatment as compared to strabismic and anisometropic amblyopia, and really cannot be compared with the two, and most RCTs on amblyopia exclude stimulus deprivation amblyopia. Patching as a therapy has been followed for more than 1,000 years, and I would like to go a little bit down memory lane. I found this very interesting article. This was Professor Bahngatter in Germany after the Second World War. He was so passionate about treatment of amblyopia that he set up these amblyopia treatment schools. So this entire building was devoted only for the management of amblyopia. Children were actually admitted there for a period of several weeks. They stayed in the hospital, they received the schooling as well as amblyopia therapy while they were admitted over there. And this is a poster suggesting that amblyopia needs to be screened for in very young children if we are to be successful in treating it. So coming back to our current practice, the gold standard is total occlusion to form in light, which means usually these are occlusive adhesive patches. We don't want to use stick-on patches over the glasses and so on, because it's very easy for the child to peek, especially in dense amblyopia. The infant aphakia treatment study suggests 1 hour per day per month of age till 8 months of age, and 50% of the waking hours after that. Moderate amblyopia between 2040 to 2080 can be treated with 2 hours of patching along with 1 hour of near work. Severe amblyopia, more hours of patching works better, so about 6 hours of patching with 1 hour of near work. Atropine penalization is found to be equally effective as patching in mild to moderate amblyopia. It has been suggested that patching, combining patching and atropine may offer some advantage. The major issue with patching, as we all know, is compliance with patching, and we never really know whether what we are advising and what we are getting, whether there is any correlation between the two. The monitored occlusion treatment of amblyopia study has found that patients may be patching less than 50 hours of the 50% of the prescribed hours, and in fact this has been given as a reasoning why the ATS study found that in mild and moderate amblyopia 2 hours may be comparable to 6 hours, because you may be prescribing 6 hours but the patient may actually be doing only 2 to 3 hours. Educational intervention with counseling of the parents, showing them cartoons with popular characters wearing patches and rewards are helpful in ensuring compliance. This photograph shows an occlusion dose monitor to study their thermal sensors embedded on internal and external surface to detect the duration of patch use. These studies have also enabled us to know what is the dose response relationship, and essentially approximately 120 hours of patching for 1 line of improvement, and this is usually in the early stages. Of course, this goes down as the amblyopia improves. In the early stages, maybe 50 to 60 hours of patching may get you 1 line of improvement, and once you're on those last 2 lines, child improves to about 612, it becomes very resistant. So these are the demand for new approaches. Why do we need new approaches? We want approaches which will work faster, which will facilitate compliance, which will give us more complete resolution of amblyopia without recurrence, which are effective and practical in older children and adults as well who cannot patch for many hours. So the first of these are liquid crystal glasses, which are basically just a modified way of occlusion therapy. So these are electronic controlled occlusion. There is intermittent flickering of the lens of the better eye, so that it provides patching for maybe 30 seconds at a time. It can be programmed to how much of patching you want. So it may become opaque for 30 seconds out of 1 minute or 15 seconds out of 1 minute. So it has an on and off mode. It's cosmetically acceptable, as well as refractive correction can be given in the same glasses and may be comparable to patching. The newer therapies which we now have are can be divided into 3 categories: perceptual, dichoptic, and virtual reality. Virtual reality is just a platform which can also provide dichoptic therapy. So perceptual learning and revital, I think, is the most common example for this. This is based on the principle that practice makes perfect. So the patient or the amblyopic eye is trained in spatial frequencies in a range that can be improved with repetitive practice of a software based visual task, improving visual performance by inducing plasticity in the visual system. So the various types of tasks which they perform include gabor detection and letter identification and noise. This is an FDA approved treatment, and it is claimed that it offers up to 2.5 lines of improvement and 100% improvement in contrast. These are the kind of tasks which need to be done. The first one is a darker image task, where you may have to identify which is darker, which is lighter. The second one is where the target is present, and the third one which is shifted, which has an offset, and so on. Practically what we find is that it's quite a tedious therapy, especially for young children, and they tend to get bored and quit quite early, because there are no colors, there's nothing very attractive to hold them to it. But older patients who do it definitely report, we've noted about 1 to 2 lines of improvement, but the problem is that does it lead to any improvement in a practical sense for them? So coming to dichoptic therapy now. So the major disadvantage of patching is that patching is only focusing on uniocular vision. It's not focusing on the function of both the eyes together in a binocular setup. So which is the principal underlying dichoptic therapy. And this is unlocking binocular visual function by presenting independent visual stimuli to each eye, requiring the integration of the two images. The image shown to the amblyopic eye is of a higher contrast to compensate for the decreased contrast sensitivity, and the image which is shown to the normal eye is of a lower contrast. These are fun, they are shorter duration, there's no patching involved, and now passive viewing of dichoptic movies as well have come in, which don't require any effort and therefore can be used in much younger children, because it doesn't require active participation. So the first one of these, as Dr. Aditya had mentioned, was the Vision Therapy System 4, where you had a TV monitor and you had these liquid crystal shutter goggles in order to facilitate the presentation of the dichoptic targets. And this was an in-office therapy, it cannot be done at home. And it was quite expensive, so I think that is the reason for the low acceptance rate for it. This is just a kind of dichoptic therapy. There are many companies which are currently available, but the principle remains the same. The patient is given red-green glasses or blue-red glasses. The background target is presented to one of the eyes and the moving targets to the other eye, and both have to be integrated and the game has to be played in order to successfully reach the next level. So several companies are available for this at different price ranges. And finally, the virtual reality vision therapy. These are also dichoptic therapies, but which are based on a a virtual reality headset instead of using glasses and a monitor. So this video is just demonstrating how this works. So the weak eye, the stronger stimulus is provided to the weak eye, while the contrast sensitivity of the stronger eye is reduced. Ultimately, as the therapy proceeds, the stimulus is equalized between the two. So in the next video, we can see how this exactly works. So the patient or the child will wear the virtual reality headset and basically play a game for about 30 minutes to an hour per day. This is a new concept which has come out. This has also been FDA approved and is available in the US. It's called Luminopia. So instead of playing a game, many of the popular cartoon movies or series which are available for children have been adapted into this. So they claim that they have a very wide range or a wide selection of videos for children to watch. A study has been published which claims that amblyopic eye visual acuity improved by 1.8 lines compared to only 0.8 lines in the comparison group which used only glasses. And I will finally finish by, this is Dr. Santan Gopal's invention, which is the orthoptic magnocellular stimulator. And I think he has a stall over here today as well. So this believes that we have all been working on patching or by stimulating the eye, and instead of this, he believes in the concept of stimulating the central visual cortex. So stimulation of the magnocellular cells by overt and covert attention, which is basically by movement of the eye to fixate on a lighted target or to focus on one particular target while other lights may be glowing in the periphery. Leads to stimulus going to the posterior parietal cortex, increasing the lateral occipital activity. I believe there is a free paper also being presented on this in this AIOS. Our experience, essentially what we find that acceptance rates are low as costs for many of these dichoptic therapies are expensive.
Can we wrap up?
Yes. So overall, the recent plethora of therapies have not constituted the fundamental paradigm shift which we hope for, but they are effective additions to our therapeutic repertoire.
Thank you so much. And as we end the dot on time, well in time, I thank first of all our speakers for being here and sharing all your vast experience and knowledge. And thank you all of you for being here through this course. And I hope it was useful. And see you hopefully next year. Thank you so much. Thank you for being here.